So catastrophic vasculitic disorders. And off lately, post pandemic, we are seeing a lot of disorders. Okay, so coming to the definition of catastrophic APLA, it is a rare, life threatening form of antiphospholipid syndrome defined by a rapid onset of large and small vessel thrombosis, which occurs simultaneously at multiple sites, causing multi organ dysfunction. Okay, so because it is involving multiple sites and causing multi-organ microthrombosis and damage, it is called as catastrophic. Okay, so it's very straightforward. Thrombus present in multiple organs is catastrophic APLA. Okay, just remember it straightforward. Okay, so rare life-threatening form of antiphospholipid syndrome characterized by onset of large and small vessel thrombosis at multiple sites leading to multi-organ dysfunction. What is the pathophysiology? As the name suggests, antiphospholipid antibodies are produced, which causes thrombotic microangiopathy, both in large vessels and small vessels. How do they form that? Usually, there will be complement activation, which is enhanced by the antiphospholipid antibodies. This causes endothelial dysfunction and damage, and this again triggers a clotting cascade. Okay, because there is a clotting cascade which is activated, it leads to a prothrombotic state, and because of prothrombotic state and the clotting cascade activation, there will be an inflammatory response. Okay, that is by cytokines, tissue factors, etc., and this causes thrombus. Okay, it can be large vessel or small vessel. Okay, so this is the pathophysiology of catastrophic APLA. It's very straightforward. Okay, phospholipids are usually present in all the cells. Okay, so anywhere there is an antibody which can go and address to this, it gets attached to it. It starts the complement activation, endothelial dysfunction, coagulation cascade activation, and inflammatory response. Okay, just remember these headings for pathophysiology of catastrophic APLA. It's more than enough if you write it under these headings. Okay, coming to the diagnosis, coming to clinical features, usually patients come with symptoms like shortness of breath, pain in the limb, etc. Okay, sometimes they can also present with stroke, seizures, bleed, etc. Okay, so all of this is possible. The major issue is it's a multi-system involvement, and whenever you have multi-system involvement and there is possibility of vasculitic etiology which is present, especially when you feel that no other cause is correlating, then think about this patient having APLA. Okay, so always do your screening like your ANA profile and screening, and then follow it up with your specific antibodies, that your APS antibodies, which I'll be discussing later on. So diagnosis of CAPS involves identifying clinical manifestations, like I mentioned earlier, including rapid organ involvement and small vessel occlusions, which is confirmed by histopathology and high antiphospholipid antibody levels. Okay, so usually you'll have multiple issues which are happening at the same time. Okay, so we all know, right? Whenever we have a patient with a CVT, etc., who comes to us, a patient developing seizures in pregnancy, or patients who come to us for unexplained stroke, we all go ahead and do these prothrombotic workups. So it's one of those prothrombotic workups that we need to remember. Okay. So what is the classification and how do we come to a definitive diagnosis of catastrophic APLA? Okay. You have something called as the assurance criteria for diagnosis of catastrophic APLA. So there are two ways that we can, come to a diagnosis of catastrophic APLA or CAPS. One is definite, wherein it requires all the four criteria, and other one is probable. Probable is where the definite criteria are not met. Okay, so what are the definite criteria for CAPS? There should be evidence of involvement of three or more organ systems, development of manifestations, simultaneously, which happens within a week's period, confirmation by histopathology of small vessel occlusion, or laboratory confirmation of antiphospholipid antibodies. Okay, majorly all the four should be present. Okay, so histopathology need not be present. If you have any other radiological evidence, also it should be fine enough. Okay, large vessel histopathology is only focusing at small vessel occlusion. So what is probable caps on the other hand? Wherein all major criteria, like the earlier criteria, are not met, but two or more organ systems, when they get involved, they fall under probable caps. Okay. So again, timeline cannot be met. Okay, one of the four criteria will be met. All of them fall under probable caps. Coming to laboratory tests, which are supposed to be sent for the diagnosis of CAPS, we have antiphospholipid antibodies, which are they? Lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein 1 antibodies. The other ones are your routine tests like your CBC, coagulation studies, peripheral smear, organ function tests like renal function tests, liver function tests. Okay. Sometimes you might have to do your cardiac markers to rule out probability of a STEMI or an NSTEMI. You should also look for complement levels in catastrophic apla. Usually, I told you earlier in the pathophysiology, there is an activation of clotting cascade because of complement activation. And because there is complement activation, there's obviously a decrease in C3 and C4 levels. It is the complement level. How do we manage catastrophic apla? Usually, the acute treatment, the pillars of the treatment are giving the patient steroids. Okay, you have to give them pulse steroids, high dose, therapeutic plasma exchange or the use of IVIG, and then follow it up with anticoagulation. So it is called as triple therapy with anticoagulation. Okay, so this is what we have to remember about management of catastrophic apla. Okay, so first line therapy, anticoagulation. Start with heparin, then you can bridge to warfarin and target the INR between 2 to 3. Steroids, high dose methylprednisolone, usually 1 to 2 milligrams per kg per day. Plasma exchange, you can do daily session. Because this patient has a high clot burden, we have to do it as a daily session. Okay, so usually up to 7 days is what they recommend. If you are using IVIG over plasma exchange, then it is 0.4 grams per kg per day for 5 days. Okay, usually sometimes apla can be existing with patient already with SLE. Okay, if these patients are coming with severe catastrophic apla, there is recommendation for cyclophosphamide. The second line drugs which are used in the treatment of CAPS are rituximab and eculizumab. Okay, like most of the cases with autoimmune disorders or vasculitic disorders. Okay, what are the additional measures that we need to do? Organ support if the patient ends up with acute kidney injury with for any classical signs, probably this patient needs dialysis, ventilation, inotropes, etc. Okay, always rule out other issues are also associated with this. There might be infections, there might be clots which cause some organ dysfunction, sometimes bowel ischemia, etc. They might require surgery. Okay, you might have to alter some medications, okay, which is going to increase bleeding tendencies in these patients. So all of this have to be looked into and addressed. These patients require anticoagulation, DVT prophylaxis, and stress ulcer prophylaxis also have to continue. What are the sequelae of APLA? There are two major headings that I want you to understand and write this in the exam. Categorize them as acute complications and chronic sequelae. Acute complications are multi-organ failure, right? You have your multi-system disorder, I told you earlier. It can be renal, respiratory, cardiac, or neurological. Thrombotic microangiopathy leading to end organ damage, hemorrhagic complications. It can be because of anticoagulation therapy itself, okay, and infectious complications because this patient is in an altered immunological state. Chronic sequelae is this patient develops CKD, pulmonary hypertension because of, if at all the patient develops a pulmonary embolism, neurological deficits because of stroke, MI, okay, or else some peripheral limb issues. Okay, all of these are chronic sequelae. Okay, so if you categorize them like acute and chronic, it will be helpful for recalling and writing all the answers. What you write in the acute complications, just imagine that this patient has developed all those complications and survived. So if at all they have survived, what is the worst case that can they have? What is the morbidity with the acute events they have is what is chronic sequelae. Okay. So coming to the mortality rate, the prognosis is very bad with catastrophic APLA because it has a higher mortality rate up to 50% where the patients don't make it. Patients who recover usually have a morbid life. Okay, so they have a lot of residual organ dysfunction. And whenever there is one incidence of APLA becoming catastrophic, there's always a higher probability that these patients can have a worsening event later on. Okay, so they have to be under close watch. So the take-home points for this patient case would be it's a medical emergency with a high mortality rate. When there is unexplained events on your admission and wherein you think that this patient has an immunological event, think about this patient having developed catastrophic APLA. The classic triad which the patient presents with is thrombocytopenia, hemolytic anemia, multi-organ thrombosis. Okay, so remember this classic triad. Okay, earlier on I forgot to mention about this triad. Okay, but please remember the classic triad is the one which will start triggering you to look for these things. Okay, that is thrombocytopenia, hemolytic anemia, multi-organ thrombosis. Rule of threes is one thing that you have to remember. Usually, three or more organs which is involved less than 1 week. Okay, and triple therapy. Okay, when you're talking about it. So if you have all of this, probably you can write the answer. Okay, so triple therapy. Remember, high dose corticosteroids first thing you have to give, followed by anticoagulation. Either choose plasma exchange or IVIG. Okay, so you have to continue anticoagulation once until the patient recovers, and probably they might require lifelong anticoagulation. Okay, that is one thing that has to be stressed to these patients. Refractory cases, you can use second line drugs like cyclophosphamide, rituximab, or eculizumab. Okay, you have to remember the sequelae. Okay, and then also prime these patients for further issues. Like if it's a female patient, tell them that if they ever get pregnant, they're at a higher risk of developing catastrophic APLA at the time of pregnancy. Okay, always, catastrophic APLA mimics TTP-HUS. Okay, only thing is TTP-HUS, you have patients having the ADAMTS levels being very low. Okay, here in this we don't have any such issues. Okay, more likely the problem here is the patient has autoantibodies for antiphospholipids and a multi-organ involvement as compared to TTP. Okay, TTP usually neurological symptoms predominate, but here it can be any organ. Okay, so there are certain differences. The major difference being the ADAMTS level between TTP and HUS. Okay, so always look at the precipitating factor which caused this. Usually there will be a precipitating factor. Don't think that APLA just happens on its own. There will be an inciting factor like what we see in diabetic ketoacidosis. Okay, look at that, treat that.